Fires, you're going to explain the procedure, and then you're going to gather your supplies. So then you're going to come to the bedside and you're going to do a quick assessment of Mr. Edwards. So you're going to put your ears on. First you're going to provide some privacy, and you're just going to look at the abdomen, look for any obvious distension, wounds, scars, that type of thing. Take a quick look. Then you're going to listen, put on your ears, listen for any hypoactive bowel sounds or lack thereof. Then you're going to do a quick little feel. Is there any painful areas? Then you're going to set Mr. Edwards or Ms. Edwards up for the procedure. Prior to that, of course I managed to pick the one set of gloves that are way too small. Prior to that, you're going to ask them, have you ever had a nasogastric tube before? That's a tube that's going to go in through your nose, back behind, down the back of your throat, and into your tummy. And they're like looking at you, no, he's going to kill me. And they're going to shake their head, no, I've never had that. Okay, so I'm going to take a quick look in the back of their throat, see if they have dentures or not. Okay, I'm going to do a quick test. Can you breathe? Okay, yep. Nope, can't do it on that side. All right, so we're going to try the nostril that breathes well. Check for any septal deviation. Have you ever broken your nose? No, no bar fights. Okay, good. All right, so now I'm going to go on that side.
Okay.
But I'm right-handed, so I may just take all my stuff and go to that side. So it's not going to work if I try over there.
You can take the table.
I'll just take this. So you can use your pen light to look back there. Sometimes instead of a gag reflex, I'll just have them cough. Because if they can cough, usually they can gag. Okay, so I just make sure they can cough. So I'll have my water set up. I have learned over time, you never bring a kidney basin because that's like just, it's not going to work. So I always grab the wash basin because if they're going to throw up, that's not going to catch but a mere tablespoon of it, and then the rest is just going to be all over your bedding. So you get a little towel, get things set up, and then you're going to measure using the Hansen and the next method. Oh, I've already got tape.
Sorry.
And of course, tape sticks to everything but what you want it to stick to. Got it. So we're putting this down for decompression. So he's going to go to surgery. He's going to be NPO, so we're going to decompress him. So we're going to measure from his nose to his xiphoid, and the xiphoid is right about there. So it measures about 58 centimeters. So remember that, 58 centimeters. And then the Hansen method is 50, so somewhere between 58 and 50 is the measuring, okay? So some happy medium in there. So we'll just pick 55, and that's where I'm going to put my little piece of tape. Because you don't want to go down too little, because then you run the risk of them aspirating because you haven't put the tube down far enough, especially if you're using it for medications or for putting tube feeding, and you don't want to put it down so far that it curls in the gut, because then it's not going to do what it was meant to do if you're using it to suction gastric contents out of the gut. I don't know why I put gloves on when I'm attempting to tape, but I did. So what did I say, 55?
Mm-hmm.
So I'm
you have to have gloves for this part though, right?
No.
No?
I mean, it's messy. It's gastric secretions.
But it hasn't gone into the patient
It hasn't
yet.
gone into the patient yet, so. grab that. Thank you, Dana. I trust you. So now, this is where you lube it up about 3-4 inches. I forgot to grab. Is there a little piece of lube there?
This one's open.
That's fine. We'll use it. So, and then you can put a little curl in it, because these smaller ones are the ones that are the hardest to get down. The 16 and the 18, they're pretty easy to get down. It's the 14s that are a little problematic, and they get stuck in the back of the oral pharynx, and people tend to gag on them more and have a little harder time swallowing them down. So sometimes you want to dip these in some ice water so that the tip stiffens up a little more and it's a little easier to guide it down. So once you've got a little curvature to it, you're going to smear it with some lubrication. And then you're going to attempt to get your patient's cooperation. And you're going to explain, so I'm going to insert this into the tip of your nostril, and then when you feel it at the back of your throat, instead of gagging, I want you to start swallowing, okay? Sometimes you have a nurse to assist you, most of the times you don't, so you're kind of the coach and the bad guy all at the same time. But you're going to assist me, so you're going to be my able assistant. Alright, so when you feel this hit the back of your throat, I want you to start swallowing. Okay, nurse, I'll try. Alright, it's hitting the back of your throat. Swallow, swallow, swallow. Swallow. There you go. Swallow, swallow. We're almost there. Okay. So now at this point, we're in. He's tearing. He doesn't like me very much because this has basically hit the top of his maxillary sinus, and that is very painful. So that has already caused him to tear. It's like this searing pain, and now it's gone back into the posterior pharynx area, down the back of his throat. The minute it hit back there, it causes them to want to gag because it's hit the gag reflex. And here I am saying, swallow, swallow, swallow. So they're trying to swallow all when their natural reflex is wanting to, I want to throw this thing up because it is like tickling my gag reflex. So they're attempting to swallow, swallow, swallow. So now they have this tube right down the center, and it's just irritating as all get out. So they're constantly swallowing against it. They're going to be nauseated for a little while until the back of their throat is used to having this hard neoplastic tube back there. Okay, so right now I'm holding it in place until whatever hospital policy dictates that I ensure that it is truly in the right place. So my hospital policy says that I can do the whoosh test. Okay, so can somebody grab me the whoosh device? Remember, don't lose this. If you lose this, you're in trouble. So you're going to put on your ears, and you're going to listen when I swoosh. So fake put on your ears. Oh, you have ears. You put on your ears. So then you're going to put it above the stomach. And as I'm holding it in place, I'm just going to jam some air in really quick. And then you're going to say, yeah, I heard it.
I hear the swooshing.
Okay, so then she heard the swooshing. So then sometimes if they haven't had anything in their stomach, you can attempt to pull back and see if you get gastric contents. What color are gastric contents? Green, yellow, brownish color. If you get what looks like granulated coffee, brownish, then you are in the gut, but that's not a good thing, okay? That means that blood has been digested in their gut, and that's coffee ground material, and if you were to test it, it would be heme positive, okay? So I pulled back some gastric contents. I'm going to carefully put it back in. I'm going to stabilize my tube, and then I will go about either hooking it up to low well suction or whatever I may have to do. If the proctor asks you to lavage it, then you're just going to fill up the container with some lavage, and you're just going to demonstrate how you would lavage it. Y'all remember how to do that?
No.
Could you show?
So to tape it, you just create a little 1-inch base, and then you divide the tape in half. Put the tape on the bridge of their nose. At this point, you no longer need the gloves. And you can do a little courtesy hand at the tab at the end. So you want to get the tube in the neutral position, so you're going to start with one end or one tab. And then you're going to go in the opposite direction with the other tab. And then it gets checked every 24 hours, okay? And you might have to change the tape because people sweat, they get hot, and the tape is going to basically come unglued, for lack of a better term. So usually about every 24 hours, you're retaping it, cleansing the skin, getting that glue gunk off their skin, and assessing their skin for any signs of breakdown, okay? So, I heard the doctor say that they wanted me to lavage it, so I'm going to lavage it for the presence of blood or what might be in the stomach. So I'm going to go to the supply room, gather my supplies. And you always lavage with normal saline, okay? Because you don't want to disrupt the electrolyte balance of the gut. And what is the position of the patient once they have a nasogastric tube in place?
30
At least
degrees
30
or higher.
degrees at all times, okay? Because we have now created an opening between their gut and their airway, okay? Because we have opened up their pyloric sphincter.
Dr. Keegan,
Yes.
are you really going to put water in him right now?
Does he have a gut?
He does, but it's been not going into the stomach every time.
So we checked it
So we
last
need to
time.
check, yeah.
So you were setting me up for failure.
No.
I told you ahead of time.
He seems to have the gut that is connected. So we'll
But
close.
it didn't go like actually down the tube into the stomach the last
Do
time.
you feel it?
Last time it coiled in the mouth and it was like shot out.
All lavage with air. This one's not cooperating.
Why would you do a lavage?
So you're asked to lavage for the presence of blood in the gut. Okay, so usually it's done in the emergency room. They come in, they say they've been vomiting blood. So the physician will say, okay, put it in a nasogastric tube and either lavage until clear or lavage for the presence of blood in the stomach. So you put down a tube and then you'll get your irrigation device. You'll fill it with some saline and then you'll bring up 60 milliliters of fluid. You'll insert it, you'll push it in and pull it back in one quick motion, okay? And then normally what you would do is you would put this into a container and you either look for frank blood. What color is blood? Red. So you'd either look for red, you'd look for coffee ground material, which is digested blood, or you would get the gastrocult and you would test it for the presence of blood. If it was positive, then the tube would stay in until the physician ordered subsequent tests like barium swallow, go down to GI lab and have them scope the gut and see where the ulceration is and see if they can't cauterize it and that type of thing. So basic, or they might say, okay, yeah, he's bleeding and he's got clots, but we need to lavage him till clear. So in that scenario, you're just going to be filling up the container with saline. You're going to have some large bowls and you're just going to be lavaging and pulling out and dumping, filling up. Until you get all the clot material out. So you want what's coming back to you to turn into like this light rosé color. So you want to get the clots out of the gut because clots in the gut cause them to vomit. Okay, people do not digest blood well. Okay, so it makes them sick and they will eventually vomit. So usually they'll be lavaged until clear. So that could take up to 3 liters of normal saline to do that. Usually after about 3 liters you stop and let the physician know what your success or lack of success was.
Do you keep this NG tube like this, or is the saline part supposed to be open?
If they're not hooked up to anything, you cap it. Otherwise it's going to leak all over the place.
But wouldn't the gastric contents go back into the air part?
Not if you keep it above their head.
Okay, so we don't need that green cap.
I've never seen a hospital yet that has that nice little green cap, okay? So I'm telling you the reality. You cap it with what you got. So sometimes people will steal the end of the piston syringe, use that as a cap. You can do that. But those fancy little caps, they're never to be found, okay? So most of the newer Salem sumps, they have a little air vent, and so you can cap it with that, and it doesn't affect the venting process. Most of the time, you're hooked up to a low wall suction type like device. And remember, even though it's hooked up to suction, the air vent still has to be above the patient's head. Because if it was down like this, it would still cause that passive flow of gastric contents into the bed, and then you'll be cleaning up a messy bed. And then secure this to his chest with the rubber band and tape or whatever device that your facility might have. All right, any other questions?
At what point do we need to get the chest x-ray?
Right. If your facility says you cannot do anything with this tube until you get a chest x-ray, then you're going to loosely adhere it to the nose, and then you're going to order a chest x-ray.
So you wouldn't do the air or any of that?
You wouldn't do anything. You just put it in, tape it, clamp it, make sure it's not going to leak all over the place, and then get an X-ray. Okay. But you know, if stuff is spewing out of it, I would obviously connect it up because it's obviously in the right place. You can obviously take things out, but they don't want you to put things in until it's adequately determined that it's truly in the right place. So if you're getting just copious amounts of bile and gastric secretions, yeah, certainly hook it up to low wall suction because that stuff needs to come out. I've filled up 3 canisters on people before in like 5 or 10 minutes. So certainly get that stuff out of them, then call for the chest x-ray, call for a bedside chest x-ray, post nasogastric tube placement, and then they'll come up and shoot it at the bedside. You can certainly take things out of the patient with it, you just can't put things into the patient with it until it's been confirmed. So, any other questions?
When we insert the tube, when do we start turning it?
If you meet resistance, okay,
Turn it
So-
towards you?
you just turn it 180 degrees. I usually go clockwise. Yes.
So if we're not doing the CT scan right away, but we want to evaluate the placement of the tube, we do upstairs, right?
You do what is your hospital's policy.
Okay.
If the policy says you get a chest x-ray or a KUB, then that's what you do.
For terms of checkoffs, or we need to check X-ray.
You will state, I will do what is my hospital policy, and then the proctor will say, okay, your policy is you can do the whoosh test.
Okay.
Okay.
And then that's when we would do the insertion of air.
Yeah.
Okay. Okay.
Okay.
Can you also do the meds,
No.
please?
But it's not in the right place on this one.
We have some.
There's one day back there.
Yeah, we have some.
Yeah.
Is that one working?
Yeah. What happened to the Mar we had? Or there's one over there.
Pressure's on. My bad. Well, we'll find out if it's fast.
No one said it.
I have all my meds now. Everything.
Don't mind me, this is just the ICU nurse coming out of me. Alright, so you got your MAR. And I'm at my Pyxis. It says at 9 o'clock I need to give my furosemide and my potassium chloride, 20 molar equivalents, and 40 milligrams of furosemide. So the drawer opens, and I think that says furosemide 40 milligrams. It's awfully small. Yes, okay, so I have furosemide 40 milligrams. So I have 2 20s equal 40, first and second check. I'm in my little Pyxis room, life is good. Nobody's talking to me because it's the quiet zone. I don't know what that is, so we're just going to ignore it. And then I got my potassium chloride. The next drawer flies open, and I need 20 molar equivalents for 9 o'clock. I have 20 molar equivalents in 15 milliliters, and check. Life is good. So now I'm going to bring my computer on wheels. I'm going to come to the bedside. I'm going to say hello to Mr. Pat Edwards for the 15th time, and I'm going to tell him that I've got his 9 o'clock medications. And one of them is his Lasix, so it's going to make him pee a lot. And so I hope you have your urinal close by, because in about 10 minutes you're going to be needing that little puppy. So let me know if you need to get up, because I'll help you. And looks like you need some help, okay? So make sure that once you give Lasix, what's Lasix?
Diuretic.
What type of diuretic?
Loop diuretic.
Loop diuretic. So when that puppy hits the kidneys, it's gonna work, okay? And it's gonna work with a vengeance. So his urinal can't be like over there, okay? Sitting all nice and pristine, because when he needs it, he needs it, okay? There's not gonna be any time for putzing around, all right? So he needs to be able to grab it and do his business, because about 400 or 500 milliliters of urine is going to come flying out of his bladder, all right? And then I have his lovely potassium to counteract the side effects of Lasix. What's the side effects of Lasix?
Hypokalemia.
Potential for hypokalemia, because it's at the expense of diuresing, it diureses everything. So it also diureses out his potassium, all right? So I've checked his armbands, and he's allergic to codeine, and fortunately Lasix does not have any codeine in it, nor does potassium, so we're good to go. So at UC Davis, I have my little TV controller on steroids, otherwise known as the Rover. So I've beep, 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 and now I've gone into the room. I've validated with the patient, and now I'm ready to give my medications. So this is going to be my little med sheet. I don't know why I have these gloves on. They're just making my fingers sweat. Now at UC Davis, you would crush these and then take them into the room and barcode them, okay? And try not to destroy the barcode, because then you have to start all over.
Would you scan them before you crush them then?
You scan them, then you crush them, then you take them into the room, and then you do that. You open them in front of the patient, okay? And you validate in the room that you've got the right patient for the medicines that you took out of the Pyxis. What surprises am I going to find in here? Not too bad. So crushing medicines, you want them to get as fine as possible, okay? You don't want pieces of chunks, okay? Chunks will clog up your tube. Never put medications down a small little weighted feeding tube. If you want to clog your feeding tube and cause all sorts of havoc, try and put medication down a silastic feeding tube. Your nurse will hate you for the rest of your clinical rotation there, okay? So please don't do that. Because those silastic feeding tubes are about a size 10 French. So that's all they're good for, is tube feeding. Nothing else. Yep, that little guy right there.
For NG2, the Frenches are indicated for certain people, or what would, like, why would you have a certain French for certain people? It's not like catheters.
Well, yeah, an 18 French is bigger than a 10 French. So 10 and 12 are usually for pediatric or very small adults. 14 is about the smallest that you would put down an adult, usually size 16. 18 if you're trying to lavage out clots and things like that. I would put an 18 down if you're putting medicines down it, because then you don't run the risk of clogging it. So this is sterile water. Most hospitals use sterile water because they have found that the tap water from the sinks all contain listeria, so they try not to, and other organisms, so they try not to use tap water on these already compromised patients. So that's why most of the hospitals will use sterile water.
Why would you use sterile water instead of normal saline for medication?
They just decided that small enough amounts of sterile water is not really going to upset the balance, because a lot of patients are getting tube feedings, so they need some free water just because of the high sugar content and the high protein content in the tube feeding. So they need some free water. So they figure that it's okay to give them sterile water with the medicines.
And you have to keep track of the sterile water that you're using to input as intake, right?
Yes. So you want this to dissolve as best as it can. So that's why you mix these first, and then you start preparing the rest. So that by the time you're ready, then they should be pretty well dissolved. Normally what we use at the hospital are those little medicine cups, so you can just pour 30 milliliters and do it much easier. So this is my flush, med, flush, med, flush. Alright, let me get another pair of gloves. So then your third check is when you hit the button or you wand your final med. So kind of hard to, I've already dissolved it, so I've got my two wrappers. So I've got my furosemide 40 milligrams. It's now crushed up. It's in a semi solution. Third check at the bedside. I've got my potassium chloride, 20 molar equivalents or 20 milli equivalents to give to Mr. Edwards. All right, so we've done our third check. Now is the time to assess Mr. Edwards. So Mr. Edwards has a nasogastric tube. It's about at the 53 and is right near. Currently it's capped off, so you can look, listen, and feel. See how things are going. Before you insert anything into it, you either have to aspirate back for the presence of gastric contents, or you have to push air into here for the gurgle. Okay. Nothing worse than shooting some medicine into their lungs. That's a bad thing. Or normal saline. Normal saline is just gonna, or water. Water's gonna make them cough like crazy. Okay. So I've aspirated back. I got the green, gold gastric contents. So I'm pretty satisfied that it hasn't migrated anywhere. I checked the chart. It's at the 53 centimeter mark. That's where it was originally placed. So I'm pretty happy. So because I went to Sac State School of Nursing, I'm going to do the gravity method. So the first thing I'm going to do is put my flush in. Oh wow, it's working. It's good. So remember, you can regulate the flow by up and down. You don't want any air. Air is bad. What does air cause? Gas. Bad enough they've got an NG tube in their gut. They don't need extra gas. So flush. Med.
For purposes of checkoff, will you allow us to do flush, med, 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 flush? Or do you want us to go flush, med, flush?
Probably flush, med, flush. And then you'll regurgitate to the prof that now I'm going to let the medicines dwell there for about a half hour before I either reconnect them up to their tube feeding or to their suction. Because there's no point in putting stuff down there and then hooking them up to the suction, because what will happen? You'll just take it all out. If you hook them up to their tube feeding too fast and you put some medicine down there that was either calcium based or mixed in an elixir, it could denature. One, it could either bind with the calcium and be rendered ineffective, or if it is in an elixir, i.e. in alcohol, then it could denature the proteins of the tube feeding and render the tube feeding ineffective, or could potentially clot the catheter. Okay? So that's why you wait a half hour. Dilantin, once again, hates everybody and anything. So Dilantin, you stop the tube feeding a half hour before, you give the medication, and then you wait another half hour before you start the tube feeding if you're giving Dilantin liquid elixir, okay? Because it is just, it doesn't like anything. Dilantin IV doesn't like anybody, and Dilantin elixir doesn't like anything either. Dilantin just is a nasty medication all around, okay? So if you remember one thing when you're delivering Dilantin, remember that, is to stop the tube feeding a half hour prior. Otherwise you're going to be dealing with a clotted feeding tube. It's true. Yes. Spoken from experience.
Would you do it with any other medications?
That part is pretty benign. The oral elixir is pretty benign, but yeah, sometimes it just says sometimes Dilantin is timed so that you give it just by itself. So. Any other questions? And then, you know, you would do your charting or you'd hit the send button. And then because you've already logged into your EHR, your name is already there in the background. So Big Brother already knows that you've signed in and that you're giving these medications. So by hitting the enter or the accept button on the rover, then it's all good. Then you can just clean up your stuff. So how many milliliters of flush did I give? 3 times 30? 90, right? And then how many milliliters? So this was about 30 milliliters that I diluted the pills with. So there's another 30. And then this was 15. So that's 45 milliliters of medication and 90 milliliters of flush. So altogether he got 135 milliliters with his medications. Okay? So you have to count that as intake. Easy squeezy, right? And then you'll clean everything up. 4 for the door. Make sure he stays in what position? At least 30 degrees, okay? Because what if you just laid him flat? Oh, he wants to lay flat. What's going to happen? He's going to aspirate, okay? Good job. Practice. Now practice.
Thank you.
Thank you, Dr. Keegan. Thank you, sir.